Il y a du son. Il y a un son. Il y a un son. OK. Maintenant, le stylet VS. Il y a un bon son. Yeah, mais unfortunately, sur YouTube, il n'y a pas de... Les gens écrivent... OK, anyway. Je crois qu'ils peuvent... Ceux qui sont sur YouTube peuvent se connecter. On a encore de l'espace sur le Zoom. OK, docteur. Alors, notre premier exercice, c'était de... Nous sommes en train de faire fever. Okay, when a patient comes in your office and say, "Doctor, I'm not feeling well because I have this chill or I'm shivering or fever." Selon les cultures, la fièvre est différemment exprimée. Alors, là, le diagnostic différentiel pour la fièvre est vraiment grand. Hein? La majorité des fièvres sont d'origine infectieuse. That's the majority. That's why I say let's write a list of non-infectious origin of fever. So the patient who comes to your office and say I have fever, first think about an infection. That will be the most probable diagnosis. Alors, the diagnosis of fever, we also need to know that fever is actually not only a disease, it's usually a sign of another disease. So it's a symptom or a sign when you measure it. When the patient expresses it, it's a symptom. So, and fever is also beneficial in some of the cases because when you have a viral infection, you actually need fever because fever will make your cytokine to work better. Fever will assist your T cells to be more effective because it helps to recruit more T cells. So fever is not always bad as we can imagine. But there is this debate on fever in children because fever in children, any fever above 38.5 is actually a concern because not only it can bring a seizure in 5% of kids, but it's also signing something more serious. Mild fever, it means everything below 38.5, above 37.7 is actually mild. It's usually viral. And this is the majority of fever. That is actually the 80% of fever that you'll find in primary care. And we all know the mechanism of fever. That's why when you discuss fever, the patient comes with shivering, chills, feeling cold. So if a patient says, I'm feeling cold, actually it might be a way of expressing fever. And the mechanism is simple. If you remember, your hypothalamus regulatory temperature center will actually raise the core temperature or the reference temperature to a temperature that is higher. So your body must actually keep heat. One, by producing more heat, and this is more usually by what we call lean muscles. Ça produit ce chill-là, ce shivering. So muscles contraction will produce more heat. On the other side, you'll actually decrease loss of heat by closing up your pilosebaceous glands. So there will be no sweat. Usually during fever, there is no sweat. Sweat actually helps to drain out fever. We are all familiar with malaria. So when the fever is breaking down, they tend to sweat because by convection, the heat will then be lost by the sebaceous gland. So you have those two mechanisms of fever. Very important. That's why the patient will not come only with, I'm having fever. He can say, I'm getting cold, I'm shivering. And this patient, usually when they start producing fever, they tend to cover themselves because the hypothalamus is actually requesting for more heat and will then make the patient to keep that temperature going up. Now, it's also important, we are using nowadays what we call a infrared thermometer. So remember, when you use the core temperature, which is very difficult to measure, the core temperature, you need 37.7 to say that someone has fever. But if you are using oral or rectal or axillar thermometer, that is usually no longer used nowadays, or even you use the skin patch, which is usually very inaccurate. The level of fever changes, but nowadays we use infrared thermometer. With infrared thermometer, the cutoff for fever, you must actually add plus 0.8 degree. So if you pick up 30 degree with your thermometer, it means that patient actually has 87.8. So that's already a fever. And if your patient has 37.7, it means there is already a moderate fever, because if you add 0.8, it's 38.5. I lost my picture. So that's for fever. So what are the differential diagnoses? The differential diagnosis of fever, of course, it's infection. That's the first one. Infection, and the first set of infection are viral infection, and depending on what the patient will express to you, you need to look. Usually in kids, those are upper respiratory tract infection that are usually seasonal. The second set are bacteria infection, and bacteria infection, it's the most serious one. Now, the big difference between viral and bacterial infection is that once you have bacteria infection, the accompanying signs are usually coming from only one regional site. So bacterial infection will not affect two sides of the body. So you'll have a pneumonia, is going to be a specific lobar pneumonia or very localized infection. On the other side, when you have viral infection, viruses can affect many sites. So you'll have someone with sore throat, with runny nose, with cough, but he might also have earache, hyperemia on the pharynx. So viral infection, especially when it's the upper one, will affect many sites, and bacteria will be very localized. So those are the two common cause of infection, but all other kind of infection can also bring fever. Fungal infection can, especially when they are systemic, can bring fever. Protozoal infection can bring fever. Tick bite can also bring fever, and this is very relevant for those who are coming from traveling. So malaria, which is a protozoal infection, and tick bites need to be included when someone has a history of traveling. And we'll see when we are taking history, after you've done your differential, when you have to take history, you must take the traveling history. Now, non-infectious cause of fever includes cancer. Remember, the mechanism of non-infectious fever is mediated by cytokine, the cytokine. Everything that can influence or raise a cytokine, especially interleukin-6, will actually affect the core temperature or the hypothalamus regulator of temperature. So cancer, especially advanced cancer, can actually present itself with fever. So that's the first one. The second one is allergic reaction. So someone who presents with allergic reaction will have some kind of mild temperature, elevated. The third one is collagen disorder, especially lupus, but also rheumatic arthritis and all others. So collagen disorder, lupus in number one, and all others will also bring fever. Drugs. There are drugs that can actually bring fever. The first set of drugs that we need to know are anti-epileptic. Anti-epileptic can themselves also bring fever. Usually when you stop the medication, in the next 2 to 5 days, the temperature will go away. So always keep in mind that the drugs themselves can bring temperature. Anti-epileptic like phenytoin, like barbituric, phenobarbital, and all others, they can bring temperature. Cimetidine can actually cause temperature, and so on. So after drugs, any granulomatous disorder or sarcoidosis, all those cold abscess can actually bring temperature. Heat stroke, which is an environmental injury caused by elevated temperature, can also bring fever. So it's important to know non-infectious cause of elevated temperature or fever. That was the question. I think we all got an answer to that question. Now, once you have discussed or the patient has told you, doctor, I have temperature, I have fever, I have chills, I'm shivering, I'm cold, sometimes you must think about fever, and this differential diagnosis must open in your second head to say, oh, am I dealing with a viral infection? Where is this infection? Anatomical. So it's infection, but where is the anatomy of this infection? Is it bacteria? If it's bacteria, it's going to be one site that are usually affected. If it's not viral or bacteria, then you think about all other kind of infection, fungal infection, protozoal infection, or tick and rickettsy. Think about traveling for those ones. And then you have non-infectious cause of fever, and we've named them: cancer, especially advanced cancer, collagen disorder, allergic reaction, drugs, granulomatous disease, and heat stroke. Now, the doctor should, after opening that differential, of course, proceed with consultation by saying, tell me more about your fever. So the patient will say, this fever comes, now and then, but when I take Panadol, it goes away. So the patient will give you a certain number of information. When you take over examining or questioning the patient, you should do your PQRST to qualify this fever. What is provoking the fever? Is there any underlying or precipitating factor? What is the quality of the fever? What is the pattern? Is the fever coming for a few hours? Is the fever not going at all? In collagen disease, you'll have an ongoing fever that is never going back to normal as long as the crisis is there, but it's usually a mild one, so that the quality. Is there any other related symptom? So with the fever, is there pain somewhere? Is there sore throat? Is there headache? Is there chest pain? Is there any burning urine? Is there cough? So you need to look for any other related symptom. Severity of fever. So you need to measure, in this instance, the temperature to know if the fever is mild, moderate, or even a fever above 39, 39.1 or 39 in general is a severe fever. And then the time, if this fever is it's a new, or the fever has been there for long, and so on. Now, after you have taken all this, you'll already have an idea about, okay, out of my differential diagnosis, I'm dealing with a bacteria kind of infection, or I'm dealing with a viral, or this is really confusing. This patient don't have any runny nose or cough or pain anyway, but this patient just started some medication, anti-epileptic medication. So you know it's drug. So you then need to examine your patient with your differential. Of course, you do your general examination. You look if the patient looks septic. Should I worry about these kids? Is not playing, is lethargic. Or if you take the vital sign, including the temperature, that will give you the severity of this fever. And then you do a general examination, looking for if there is jaundice, if there is cyanosis, if there is, and then you do your what we call loco-regional or focus examination on the system. Is it an ENT examination, chest, and so on? And of course, before you finish, you need to do some bedside examination. It's very important for kids. When the infection is not clear, the first investigation is your urine dipstick. You must do the urine on all the kids who are coming with fever with no specific site of infection. Of course, you need to do more than that for all others. The traveling history is very important. If there is traveling history, you must think about all those diseases from the origin of your patient. It might be malaria, it might be tick bites, it might be all other diseases. So think about investigating malaria with a malaria smear and so on. And all other tests include your white cell count. So you want to know if you have lymphocytosis, lymphopenia. Remember, viral infection will give you lymphopenia. So just a simple white cell count can actually give you an idea what you are dealing with. You have to do your chest X-ray if you think about any bronchitis or pneumonia or emphysema and so on, tuberculosis. And of course, if this patient is coming with other signs like joint pain or malar rash, you investigate for lupus or all other collagen disorder. And of course, lumbar puncture, blood culture for sepsis and meningitis should actually be done if you think is the case. Now, and this is important for the written part. There is for kids between 3 months or below 3 months, any fever that is severe should actually be treated in emergency with a step dose of antibiotics. So you don't wait. So as soon as you establish that I'm dealing with a fever, and the temperature is 39 and plus, those patients should actually receive antibiotic. And usually it's ceftriaxone that is given 50 milligram per kilo state in emergency. Can be given intramuscularly or IV, and then the kids should be admitted, because on the extreme age for infant and elderly, the temperature usually is not, if you have a temperature that you can measure, it's serious. It's usually sepsis until proven otherwise. So very important. And of course, if you have fever and petechia, so fever, petechia is also very, very bad combination. You should think about meningococcal disease, and those patients should also start beta-lactamate directly in emergency. Now, the treatment for fever, of course, paracetamol, ibuprofen for kids are used as antipyretic. You need to treat the cause because the fever itself is just a symptom in most of the case. If the fever is caused by drugs, and we have named some of the drugs, you need to stop those drugs. And in the next 2 days, when there is a washout, the fever will actually stop. There are few measures that you can do for the kids to treat their fever. And we know them. You need to increase fluid intake. You need to look for the cause, of course. Paracetamol and ibuprofen can be used, as we have said. Okay, now, some author will say that you can use sponging. You use water and wet sponge, especially in the first 30 minutes with paracetamol. And the mother or the parent must actually know if this is not responding, the fever is still there. They mustn't just continue using this method. They must actually consult because this fever can actually hide something more serious. So that's it for fever. Any question before we move to the next one? There are no raised hands. Any question? Yeah, I see one hand. Okay. Yes, Dr. Kunda.
Yes, Doc. I would like just to ask one question about the fever. You just said that we have fever which can be infectious and non-infectious, but you said that most of the cases we have the infectious causes. But in which categories falls the fever of unknown origin?
Yeah, fever of unknown origin are very peculiar. They are standing alone. You cannot actually categorize them because that's why we call them unknown origin. And fever of unknown origin, there is also a protocol to actually deal with them. The first step with fever of unknown origin is that you need to stop everything. You go back to history taking. So when you have fever of unknown origin, you must consider that, okay, everything that I know about this patient, I just stop and I consider this patient as new. So you start first to retake history. The second step, of course, you need to do a full examination. So you don't do a focus examination. You need to do a full examination. Remember, fever of unknown origin usually happen in people with immunosuppression, diabetic, HIV, people who are using arthritic patient, they are on immunomodulator for long, elderly, long-term admitted patients who were already like on antibiotics. So you need for those patients to take the full history, to do a full examination, and you need to stop to confirm that you are dealing with fever. You stop antipyretic, so you need to observe the pattern. You also stop antibiotic. You only give antipyretic in that case when the fever is now severe. So if anything above 39, then you can intervene. So you leave the fever taking its course as long as it's not reaching 39 and more. You must, on day 2 of stopping antibiotic, do what we call a serial blood culture, especially when the fever peaked. You must take at least 3 blood culture. They must be separated by 2 to 6 hours between them. And you need to run also imagery. So you do ultrasound, you do urine culture, you also do X-ray and CT scan if needed. And so you are using the inductive method here. Only when you gather all those information from history taking, from examination, from investigation, you then sit and say, what am I dealing with here? What kind of white cell I'm having? What is the formula for the white cell? What are the results for the blood culture, the early result, and so on? And only when you have done this, you have covered your blood culture, you can then reintroduce antibiotic. Of course, in your history, you must know what antibiotic you have been giving before, because usually those are antibiotic resistant infection, so you need to be aware of that. So unfortunately, you cannot classify them because remember, you can have a patient who is admitted in the hospital for seizure, and along the line, the patient start having temperature. So you might just have a phenytoin-induced fever on this patient. You might have sarcoidosis. And you know, sarcoidosis sometimes might be a latent problem. So the patient will not actually present with sign of sarcoidosis. He might be admitted for something and start having this fever until you actually go and do a chest X-ray, do a ESR, you'll then see, oh, I was dealing with a patient with sarcoidosis as comorbidity. So it's a protocol on its own, and you cannot classify it before. You only investigate it with that protocol. I think it is not covered by this book, but if you read all other books on fever, they actually cover it very nicely. So just because you are asking this question, if you have a persistent high fever, you really need to be worried. If you have fever after a full course of antibiotic, you also have to be worried. If you have fever on a kid that is drooling, is usually epiglottitis, you need to actually examine the throat, and this patient needs an admission because epiglottitis is actually a pediatric emergency. If you have a fever in immunosuppression, like diabetes, think about a candida, which is a fungal infection. So examine your oropharyngeal area, examine your genital area, and you can do a beta-2 glucane that actually shows you that there might be a fungal infection somewhere. So think about fungal infection. So very important. Any other question? Sorry, I was just drinking some water there. So let's go with sore throat. Sore throat is our fourth complaint or reason for encounter, reason for consulting. And it usually, the patient will come for sore throat. It's actually 5 to 7% of consultation in primary care, if you remember. And majority of sore throat, when someone comes with sore throat, your differential must include viral infection, usually upper respiratory tract infection, which are usually viral. They might be bacteria, and there are plenty of bacteria that cause sore throat, Streptococcus being the most common one, but you can have Staphylococcus as well and all others. You need to think about when you have sore throat, especially on older people. Think about cancer, especially if there is smoking, history of smoking, dysphagia. Think about cancer. So cancer, very important. Abscess, peritonsillar abscess are also one of the cause of sore throat. In younger kids, they won't actually tell you that they have sore throat. Sore throat is, they will present, or the parent will actually claim that the child is no longer feeding well, or the child is vomiting. And so here, of course, you must include, you must put them as sore throat, upper respiratory tract infection, and you need to go and examine. So how do you, as we say, 50% of sore throat are usually pharyngitis, and pharyngitis are mostly caused by viruses. And for viruses, you'll have more than 2 symptoms. So they will come either with coryza, runny nose, cough, conjunctivitis, nasal congestion, and so on. Those patients don't need antibiotic, and we'll go through this debate, how to, when do you give antibiotic on such. In your approach, we also say that every time you have cough, sore throat, and those are immunosuppressed patients, you need to think about other reasons for sore throat. In HIV, sore throat can just be a candida or even a cancer, so think about it. It might be a foreign body that can also give a sore throat. And on older people, please think about cancer. So do a direct laryngoscopy with MIRA or send to ENT for further examination, especially if the sore throat is accompanied by dysphagia. Now, the big debate in sore throat is when do you give antibiotic? When do you hold antibiotics? So this goes with how, when you examine your patient. So when you examine your patient, if you have a very localized sign and symptom, because in bacterial infection, as we said earlier, they will come with a very localized kind of sign. So you have a localized redness. So redness itself, when it's accompanied by homolateral tenderness on the lymph nodes. So if you have sore throat and you have submandibular lymph node or cervical lymph node on the same side, or even on both sides when you have a bilateral pharyngitis or tonsillitis, then you have to give antibiotics. But every time you have more than 2 or 3 signs, it means you have a runny nose, which is clear. You also have some redness on the pharynx. You don't have lymph nodes. Those are usually viral infection. And remember, this is the majority of cases. And in viral infection, the temperature is usually a mild one. The temperature will never go above 38.5. So a temperature that is also elevated, think about a bacteria infection, and you can then introduce antibiotic. We have mentioned that there are many causes of bacteria infection that can cause sore throat. The most common one being Streptococcus, but you can have Staphylococcus as well. You can have Haemophilus influenza. You can have diphtheria, gonococcal pharyngitis. Of course, those ones are a little bit less common. You can have amongst viruses, you have rhinovirus, enterovirus, coronavirus. Remember, we are on that area. Usually they give mild sore throat, but you can have Epstein-Barr mononucleosis. Those one comes with a really severe to moderate sore throat. And then, of course, Candida albicans, Mycoplasma chlamydia can also give sore throat. In leukemia, you can also have sore throat. And finally, you can have sore throat on smokers, people who are smoking. In terms of your differential diagnosis, when it comes to probability, viral pharyngitis, Streptococcus tonsillitis are the most common cause of sore throat. Chronic sinusitis with post-nasal drip can also come with sore throat, and oral pharyngeal candidiasis can also come with sore throat. The red flag that you mustn't miss when someone comes with sore throat includes sore throat with high fever. So when you have sore throat and the temperature is above 38.5 or more, think about examining this patient. Think about Streptococcus, and remember, Streptococcus can lead to other heart complications or even glomerulonephritis. So they come with high temperature. If you have a failed antibiotic, so the patient had an antibiotic but is still having sore throat, it's also a red flag. If a child is coming with drooling, when there is drooling, so it's actually drooling, you need to think about epiglottitis. In epiglottitis, those patients need to be admitted, and consider in diabetic patients who are coming candida, or if you find candida, you must look for diabetes because it's a two-way differential. Very important not to miss on sore throat in kids, foreign body. Foreign body can just present as a sore throat or a child who no longer wants to feed. So also very important. So how do you then investigate? So nowadays and elsewhere, you need to do a throat swab. First, you look at the throat. If you have white patches, think about a bacteria infection. If you have mono or bilateral lymph node, think about bacteria. Viral infection will usually not come with tenderness on the lymph node or adenitis, regional adenitis. Unilateral lymph node, sore throat, dysphagia, change on the voice pattern, so hoarse voice in elderly or smoker must include in your differential cancer. So those patients need further investigation. And so you can do the throat swab. You can send for direct examination. You can also, for some patients, include other investigation like blood sugar if he's a diabetic, or do a mononucleosis test and so on. So the treatment is analgesic and supportive treatment. So you give your decongestion medication for influenza. You can use lozenges or local topical anesthetic. They can use gargle. So it's basically a supportive treatment that you have to give. You only introduce antibiotic on the condition that we have mentioned. And now, the most interesting question that usually comes when it comes to sore throat is, when you have tonsillitis, when do you decide to actually send this patient so that the tonsils can be removed? So that's the question that people like to ask. So remember, tonsillitis that is recurrent if you have more than 6 episodes in 1 year. That tonsils need to be removed. That one. If you have peritonsillar abscess, it's also an indication for tonsil to be removed. If this tonsil is now giving obstructive sleep apnea on the child, the tonsils also need to be removed. Or if you have a unilateral enlarged tonsils in adults, so you have a tonsil that is no longer taking back its size, you also need to indicate for removal. So those are actually the most important cause of tonsillectomy in kids, but also in adults. So when do you then refer? Acute epiglottitis, we have said you need to refer. Abscess, you need to refer. If you suspect HIV, you actually need to further see this patient or refer to an appropriate clinic. Any question for tonsils or sore throat? Sorry. Sore throat, any question? So sore throat on people having oral sex, suspect STI. Yes, Dr. Kunda, you are right. So oral sex, we have mentioned gonorrheal pharyngitis or chlamydia pharyngitis. They are actually part of ectopic presentation of sexually transmitted infection on the throat area. So think about it, and the treatment should also be tailored accordingly. Yeah. Thank you for that comment. Let's take Dr. Valérie. Yes, Doc?
Merci, Doc. Je voudrais un peu qu'on revienne sur le sore throat en cas de l'infection virale et en cas de l'infection bactérielle. Maintenant, admettons qu'il y a co-infection, ou bien s'il y a infection virale et l'infection bactérielle vient se surajouter. Comment est-ce qu'on peut directement déduire que non, il y a co-infection ici, dans ce cas? Ça, c'est la première question. La deuxième question, quand est-ce qu'il faut enlever les tonsils? Est-ce qu'il faut attendre qu'il y ait accalmie ou bien on peut enlever même quand il y a le pic? Ok, c'est ça mes deux préoccupations.
Donc, la deuxième question, on n'enlève pas les tonsils quand ils sont en phase aiguë. Hein. On attend, l'épisode est fini. Le ENT ne va pas enlever ces tonsils-là quand c'est inflammé. Il voudra bien que l'infection se termine d'abord. Et d'ailleurs, c'est vous qui serez en train de soigner l'infection. Donc, le temps d'envoyer chez les ENT, votre patient aura complété l'antibiothérapie et donc, ou même, il sera déjà mieux. Donc, et on va programmer donc une intervention. Alors, co-infection, yeah, you can have co-infection when your patient arrive. The dilemma is still the same. When do you put antibiotic? When you don't put antibiotic? So the temperature is the first marker. So any temperature above 38.5. With our new infrared thermometer, you need 37 point, I think, 37.7. So if you have a patient with 37.7, you need to start antibiotic. It's more likely an infection. Streptococcus can come with only redness, but the temperature will usually be very high, and they will usually be accompanied by homolateral lymph node. So that's also an indication to put antibiotic. Of course, you might be confused to say, okay, am I really dealing with a viral or a co-infection or a bacteria? Now, in that case, if you are not sure, especially if you are dealing with kids, just put the antibiotic. And remember, the antibiotic of choice is penicillin. Phenoxypenicillin or oral pen-VK are the best treatment for streptococcus. Of course, amoxicillin is actually a third line. So the second best is erythromycin for that area, especially if you have allergy. And you only give amoxicillin as the third one. Because amoxicillin, unfortunately, don't have a good protection against Streptococcus species, which is actually affecting or can give you glomerulonephritis. So you need to balance that and put it as your third line. So oral pen-VK are the first one, erythromycin the second one, and amoxi the third one. So if you doubt as a doctor, just put the antibiotic, but put a full course, because your doubt means there might be something behind. Okay, so I think we have discussed and answered that question.
Ok, merci, merci.
Okay, so let's move on. Let's move on the last one. We are going to introduce abdominal pain. It's going to be a fast one. So when a patient comes to you and the opening complaint is, doctor, I have abdominal pain. What comes in your mind? remember we have done this, so you need to do your anatomical approach, your functional approach, your probabilistic approach. You must have all of this in your mind to say, what am I dealing with? Abdominal pain is also a very common reason for complaint. And the differential diagnosis, I think we have more than 40 if we have to name them. But you need to be very systematic on how you are actually approaching this. An acute presentation, is it a chronic presentation? Is the patient looking actually sick? Which side of the abdomen is it? So you need a lot of information, and the patient should actually take time to start explaining on the first part of your consultation. That will help you to narrow your differential. And on the second part, when you take over your questioning, your interview with the patient, you'll then have more clear idea about, you know, the quality and all other presentation of this abdominal pain. So, abdominal pain, as we were saying, the differential is actually based on when you use the anatomical approach, which part of the abdomen is the pain? Is it the upper region? On the upper region, you have the epigastric region. On the center, you have the two upper quadrant, left and right on the side. So all of them, all those three regions as their specific differential diagnosis. And then you have the middle one, you know, all the flank and the peri-umbilical area, they also have their own differential. And then you have the hypogastric and the iliac fossa that are also having their own. So that's the anatomical 9-quadrant approach, but you can also use another approach which is very functional. Am I dealing with an inflammation here? Am I dealing with a perforation? With perforation, of course, you have the quality of the pain that will be a severe, sudden onset, and so on. Am I dealing with an obstruction? Obstruction, usually, the patient will come with sign of obstruction, so you have vomiting, not passing flatus, and so on. Am I dealing with an hemorrhage? Is it a abdominal aorta hemorrhage, fallopian tube, ectopic, or am I dealing with ischemia of ovaries or sigmoid colon? So that's the functional approach. And then, of course, you have what we call the probabilistic approach. Acute gastroenteritis are on top. So patient will come, I have abdominal pain, and will then tell you, I'm also having a running stomach, I'm vomiting. So you know you are dealing with acute gastroenteritis. The second very common complaint for abdominal pain, it's also a severe one, is acute appendicitis. So acute appendicitis, especially on young adults or a teenager, you need to think about it. It's very common. Abdominal pain can also be in probabilistic diagnosis dysmenorrhea. So dysmenorrhea, and finally irritable bowel syndrome comes also as a very common one. You need to add on this peptic ulcer and gastritis. So all the dyspepsia, those are abdominal pain that are modulated or changing with food, either when there is no food or just after food, or as the patient is actually eating. The red flag on abdominal pain that we mustn't miss are the cardiovascular, so the AAA, abdominal aortic rupture. We need to think about mesenteric artery obstruction. They come also with pain, although it's not common, but we need to include it. Cancer, neoplasia, especially on extreme age. You can have peritonitis or infection in general. Peritonitis being the top one. You might have all other infection, intra-abdominal abscess, in TB, and so on. You can have ectopic pregnancy. You mustn't miss ectopic pregnancy and pancreatitis. So always think about it. And you must also think about perforation and obstruction. So those are acute and very important red flag differential that you must always include. And remember, abdominal pain can also be what we call a masquerade or a symptom that is actually made up by the patient. Patient with depression can come to consult, opening the complaint with depression. So once you have your differential diagnosis, you have qualified the pain. And how do you qualify the pain? You use your OPQRS, onset, pattern, related sign, and all other severity. You need to examine the patient. Abdominal examination must be very sensitive. So you mustn't go and create more pain on your patient, but you need to examine the patient. Your examination might have to include rectal examination. It's very important. And at the end of your examination, you need to do some investigation. Very important with your red flag, pregnancy test, the level of blood, especially if you have any bleeding or blood loss. You need to check if you are dealing with an infection. So a CRP, ESR, are very important. Check the liver function. Do now send for a CT scan abdomen, and you can also, of course, include you can investigate for pancreatitis. So once you have done all those investigations and you have narrowed now your diagnosis, you need to treat. The treatment of abdominal pain, of course, it's all related to the cause of your abdominal pain. So you might have an acute surgical intervention. You might have to give analgesic and pills for acute pancreatitis. You might have to give antacid and PPI, depending on what is your diagnosis. You might have to refer this patient or to give fluid for acute gastroenteritis. So that's for abdominal pain, which is, as we say, very common, but you need to be very systematic. One of the challenging diagnoses in abdominal pain is irritable bowel syndrome. So patients with irritable bowel syndrome will usually present with abdominal pain that is ongoing for a very long time. They might present either with a type constipation, which we call IBS type C, or a type diarrhea. And normal constipation can 7 days for those one, or they have episode of diarrhea, 1 to 3 days of a small loose stool, once or twice a day for 1 to 3 days, followed by normal bowel movement, but they present with a chronic abdominal pain. Usually this and so they will tell you that, oh, I've noticed that when I take veggies, I'm fine. When I take this kind of food, it's actually worse. And the onset is later in life. So it's also other colitis or debilitating.
Alors, docteur Jody, si vous pouvez vérifier votre micro, ça fait même 5 minutes qu'on ne vous entend plus.
Oh, sorry, that's so bad. I've been talking alone. Okay. Since when did you miss my talk there?
Et en plus, votre connexion posait problème.
Oh,
Et
yeah.
ça, à partir de là, au fait. C'est
Oh,
quand
yeah.
vous entendez plus.
Yeah, parce que ça avait coupé, hein? Ça coupé, et puis j'ai vu. Okay, so I think I was talking about abdominal pain. Did you all follow when I was discussing IBS? Irritable bowel syndrome, did you follow that?
Yes, we did.
Okay, irritable, yeah. So I was just finishing by saying what we are going to do next. So next time we are doing five complaints. We are going to cover dysuria or urinary symptoms. We are going to do low back pain. We'll do joint pain, dizziness, and chest pain. So we'll do those five. And then we are going to finish with the second part of communication skills. Then after that, we'll start the guideline, and then we'll take over how to interpret investigations. And as I say, after those five, I will be in and out. So you'll have other presenter that will come in to take you with discussion of some subject. For guideline, we say we are not going to read guideline together. It's a lot of time. To actually benefit from those discussions, the guideline will only go to technical parts and will introduce some old questions. So you need to be prepared. Dr. Chiswaka will help us to put actually a plan so that we know what guideline is coming and we can read and prepare them in advance so that we use time efficiently. Okay, so yeah, I think we can stop here for today.